Hello everyone, thank you for viewing our poster titled From Plantar Fasciitis to Polyarticular Septic Arthritis, a delayed diagnosis with severe sequelae. My name is Namra Khan and I'm excited to walk you through this case. Septic arthritis is considered a rheumatologic emergency and it's oftentimes caused by organisms such as Staph aureus or Strep pneumo. If it's not recognized early, it can lead to joint destruction, impaired mobility, and even systemic complications. Now, some risk factors include pre-existing joint disease, obesity, prior history of immunosuppressive therapy, or direct trauma to the area. And the diagnosis can be especially tricky because the early symptoms of joint pain, swelling, and fever are oftentimes nonspecific, and they can overlap with other rheumatologic conditions. But polyarticular septic arthritis, which is septic arthritis affecting more than one joint, carries a much higher mortality rate compared to monoarticular disease, and so it's important for timely recognition. So in our case here, we have a 33-year-old woman with a history of atopic dermatitis, obesity, and hypertension who presented to the ED with acute right ankle pain and fever after jogging. Initially, she was discharged with NSAIDs. She returned back to the ED with continued pain. She was evaluated by the podiatry team and was prescribed oral steroids for presumed plantar fasciitis. Over the course of a week, she continued these steroids, but the pain and swelling worsened. By day 9, she developed new left shoulder pain, and physical exam showed right ankle erythema, blistering, limited range of motion, and shoulder swelling with pain. So labs were conducted. She had elevated white blood cell counts, a CRP of nearly 300, and an ESR of over 100, which are both elevated. In the center of the poster, we see the patient's clinical course outlined. We see that by day 9, she returned back with the ankle pain and left shoulder pain. So we see on the bottom left images of the swelling and the erythema that was seen. And so a Doppler study was conducted, and it showed DVTs in the right lower extremity. So she was hospitalized for further workup. By day 10, she completed a CT scan, and it was concerning for septic arthritis. So she was started on empiric antibiotics. On day 11, arthrotomy and incision and drainage of the shoulder and ankle occurred, and the cultures were positive for group A strep. So she was started on cefazolin. By day 16, she completed MRIs of the right ankle, tibia and fibula, and the foot. And it was consistent with findings of septic arthritis, avascular necrosis of the talar head, extensive myositis and cellulitis, and multiple rim-enhancing fluid collections involving the ankle, midfoot, and plantar musculature. So she repeated an incision and drainage. On day 24, she was discharged home on oral antibiotics, outpatient physical therapy, and home health care. But she returned at around day 36, and she was admitted for persistent foot drop and pain, which we can see on the right side of this poster. A bone biopsy was conducted, and it was indicative of osteomyelitis. She was treated with 6 weeks of IV cefazolin. At 10 months, there was resolution of the osteomyelitis on repeat biopsy, and she regained around 50% of her ankle range of motion, but she was still partially weight-bearing, and she was still doing rehab. So this case underscores several important teaching points. Diagnostic delays in septic arthritis can have devastating outcomes. We see that because the patient's symptoms overlapped with more benign musculoskeletal conditions like plantar fasciitis, her diagnosis was initially missed. Her risk factors of atopic dermatitis, obesity, and corticosteroid use predisposed her to more aggressive infection. And the case also shows you that systemic inflammation and hypercoagulability can be linked because the patient developed DVTs alongside her septic arthritis. But ultimately, MRI proved to be critical in defining the extent of the disease and guiding intervention. But despite aggressive management, which included IV antibiotics, she was left with significant complications. We see that at 10 months, she was still slowly gaining her range of motion. So the key takeaway here is that clinicians should maintain a high index of suspicion for septic arthritis in patients with risk factors and unexplained joint pain, even when labs or initial imaging seem nonspecific. Early joint aspiration and culture remain essential to preventing irreversible damage. Thank you for your time.